Very good morning to all of you. Uh, as we all know that gonioscopy is the examination of the angle of anterior chamber, and this is mandatory for the diagnosis and management of glaucoma. A brief idea about the history of gonioscopy. It is Alexiotrentus, the Greek ophthalmologist, who coined the term gonioscopy. And it is the Salzman who was the first to view the angle through the contact lens. He was the first to describe the blood in the Selms canal. Why there is need of gonioscopy? Angle of antechamber cannot be visualized because there is total internal reflection at the precorneal tear film. And light rays from the angle exceeds the critical angle, so it is reflected back into the anterior chamber and thus preventing the direct visualization of the angle. In this picture, we can see that as the angle of incidence is increasing, there is total internal reflection. Three primary methods are direct gonioscopy, indirect gonioscopy, and indentation gonioscopy. In the direct gonioscopy, as the index of refraction of the contact lens, that was that of the cornea, there is minimal refraction at the precorneal tear film, and so light rays enters the eye. There are various types of direct gonio lenses. It's all about technique. So advantages are it can be used in sedated patients, and both the eyes can be examined at the same time, and surgical procedure like goniotomy can be performed. Now coming to the indirect gonioscopy, in this we use a mirror to reflect rays from the angle so that they exit the gonio lens at the much less than the critical angle, and they provide a mirror image of the opposite angle. There are the different types of. So this is important. Before doing this, room light should be dimmed, size and intensity of the slit beam should be reduced, and they do not impinge upon the pupil because they will constrict and falsely open up the angles. What we see is a mirror image. The part of the angle that is viewed is 180 degrees away from the mirror that is being used. And it allows differentiation between the appositional and sanical closure because our whole treatment plan depends upon this. So if it is appositional closure, we will do the laser iotomy. If it is sanical closure, we have to do the filtration surgery. And it can create a corneal beige. So sometimes this is very helpful in identifying the Solvi line. What are the information goals we needed? Is the angle open or closed in normal position? It is a positional sanical closure, any abnormalities in the angle, and look for occludable angles. And after that, increase the room and the slit lamp illumination, and it will open up the angles. So now coming to the indentation gonioscopy. Here the lens is moved posteriorly, indenting the cornea and forcing the aqueous to the angle, and pushing the lens iris diaphragm posteriorly. And so this differentiates sanical closure from appositional closure. In this picture, we can see that in the appositional closure, there is opening of the angles, whereas in sanical closure, there is no opening of the angles. So over the hill or dive bomber's view. This is a special maneuver in case of steep iris. So ask the patient to look in the direction of mirror or move the mirror towards the angle being viewed. So these are the indications for gonioscopy. And actually, if it is the Van-Herix grading is grade 2 or less, in that condition, you have to do the gonioscopy. There are other conditions also, but it is important. Always do the slit lamp examination, do the Van-Herix grading, and see that if the angle is narrow. So then do the gonioscopy. There are the different indications. Now coming to the normal angle structures. From anterior to posterior is Solvi line, everybody is knowing. Meshwork, non-pigmented and pigmented part. Then ocular spur, ciliary body, and root of the iris. Solvi line, this is the most anterior structure and demarcates the peripheral termination of the descending membrane. And two light reflections seen, one from the anterior surface of cornea and one from the posterior surface of cornea, and where they meet, they create a corneal beige. So this is very useful in sometimes faint Solvi line. Trabecular meshwork, anterior non-pigmented part and the posterior pigmented part. Sometimes there may be variations, like in the left side picture we can see that there is discrete line of pigmentation along the Solvi line, and in the right side of the picture there is wavy line of pigmentation anterior to the Solvi line. So that is called the Sampoleschi line. These are how to grade the pigmentation. Now coming to the Selms canal. It lies within the posterior pigment trabeculum spur. In most individuals, Selms canal is not visual. It is visual when filled with blood. And sometimes we press the Goldman lens too firmly against the cornea, compressing the episcleral veins. Blood in the Selms canal is visual. This is the most consistent finding usually, and this is the most anteposition of the sclera, and light gray in color. But there may be variations also. In the right side of the picture, we can see that there is yellowish discoloration of the muscular spur. Ciliary body band is usually light gray to dark brown band, and it's a bit depends upon the portion of iris insertion, narrowing hypermetropes, and anterior insertion of the iris, and bite in myopes. In the right side picture, we can see that bite ciliary body band. Iris processes these are epithelial extensions from the iris on the trabeculum meshwork, and it has to be differentiated from the peripheral anterior. So it inserts close to the muscular spur and often found in normal angles. This is important. In the left side picture, there is iris process and peripheral anterior. So peripheral anterior is broad, whereas this is fine. And peripheral anterior do not move with indentation, and it is not. So this is intact initiation also, rest movement, it obscures the view, and they extend beyond the muscular spur. So now coming to the normal blood vessels and neovascularization. Normal blood vessels, they have radial orientation, where the neovascularization, they do not have radial orientation. They are fine, they can branch, but normal blood vessels are thicker. These are the differentiating points between the normal and pathological blood vessels. The most important classification is ISGO classification, like PSCS, PSC, and PSCG. And these are so occludable angles is
please
PSC.
Conclude.
Yes, just. So how to document this? So this is prominent solid line posterior metoxin. This is broad iris process extending of the solid line, that is Axenfelden valley. S-separate configuration in case of plateau iris. And this is angle recession. So now I'm concluding. So gonioscopy is mandatory for diagnosis and management of glaucoma, and routine gonioscopy is essential to master the art and to differentiate normal from abnormal blood vessels. So my take-home message is start doing the gonioscopy. First start on the normal patients, on myopic patients, and then you will be able to understand the different structures. Thank you.